Perfect. Well, I know that we are always struggling to stay on time, particularly as it gets late into the evening. And so, welcome back, everyone, from the break. And it's a great pleasure to introduce Blanca Ledesma. Blanca works very closely with me clinically, and in fact, she became involved in immunotherapy much earlier than I was, being involved in many of the early immunotherapy trials in diseases other than lung cancer, and then has been part of UCLA for the last many years and was able to be part of the development of immunotherapy in additional tumor types, including lung cancer. And she will be speaking to us today. She's a nurse practitioner with great expertise, as I say, across really well over a decade of managing toxicities of immunotherapies, and she will discuss toxicity management with us.
Yep.
Okay, thank you. Well, thank you everyone for having me here today. Today I have toxicity management, and so I'm going to get started here and try to stay on time. So these are my disclosures. The outline today, we're going to discuss the incident, onset, and severity of grading, the immune checkpoint inhibitors, the common adverse events, serious adverse events, the impact of IRAEs on cancer outcomes, adverse events and management, immunotherapy in special patient populations, and a couple of case studies at the end. So with immune checkpoint inhibitors, we have these immune-mediated adverse events, and they can happen early, but we can have these delayed onset and prolonged duration of these IRAEs. And it's quite relative to the chemotherapy, as we see here with this graph, that we can have, the early with the blue line and these prolonged IRAEs, and then we see the blue dotted line that we see the waning of the immunotherapy effects. We see the blue arrow showing us the duration of the treatment effect, and then we see with the red, again, relative to the chemotherapy. And the toxicity really comes from the mechanism of action of the IO, of the immunotherapy, and can really mimic other underlying medical conditions or autoimmune conditions. And the onset could really be from days to months out. And so this is really something important because patients can discontinue treatment, and we can still see these ongoing IRAEs after they've discontinued therapy, perhaps have moved on to other new therapies. And so it's important to be aware that even if they moved on to other therapies, they can still be potentially having these IRAEs from the immune checkpoint inhibitor that they were previously on. And when given in combination with IO-IO or IO chemo, that these IRAEs can come on and have been seen to come out earlier. And as we see here, that the median time to onset, like for skin, can be 5 weeks. For the pulmonary, can be the median onset is 8 to 9 weeks, 8.9 weeks. Or the renal 15.1 weeks, but really anywhere from days to months out. And it's really important that we do identify these patients that are currently receiving immune checkpoint inhibitors or have been previously treated so that we can appropriately manage them if they should have any IRAEs. The common terminology criteria for adverse events. This is something that is so important that we understand the grading. It's important that we understand where patients' baseline is at and how they deviate from the baseline, and that we grade them. The grading is going to be so critical so that we could do the proper intervention for these patients once they develop any IRAEs. And we want to do the proper intervention so that they do as well as possible for as long as possible and don't have any harsher or more prolonged IRAEs. So, and as we see here, it's, grade 1 is very mild, a grade 2 is moderate, grade 3 is more severe, perhaps patient is in the hospital, definitely affecting ADLs, 4 life-threatening, definitely hospitalized, and 5 is death. Now moving on to common adverse events. So here we see the toxicity with checkpoint inhibitors. We see the PD-L1 pathway, CTLA-4 pathway, the combination IO-IO, IO chemo, and then chemotherapy alone. And we definitely see that the grade 3 and plus are increased when we give the IO-IO followed by the IO chemo. They're definitely increased. Otherwise, it's pretty well tolerated, with majority being all grades when given with the PD-L1 in single agent, or the CTLA-4 and single agent. But nevertheless, we still see the grade 3 and greater with single agents, but obviously greater when given in combination with the IO or IO chemo. When looking here at the nivolumab and the pembrolizumab, the treatment-related adverse events in different solid tumor types, such as melanoma, head and neck, non-small cell lung cancer, colorectal, urothelial, Hodgkin's lymphoma, cervical, and we see here overall the grade 1s, grade 2, those are the majority. We see that they're very tolerable, manageable, and actionable. And the grade 3 and plus, we do see them, but they're not as common, but nevertheless, we do want to be aware because they do happen, and we want to make sure that we do treat our patients appropriately. But the majority that we do see are grade 1s, grade 2, again, very tolerable, manageable, and actionable. Common IRAEs with immune checkpoint inhibitors are the cutaneous with the dermatitis, the gastrointestinal with the diarrhea, colitis, hepatitis, musculoskeletal, inflammatory arthritis, myositis, pulmonary with the pneumonitis, endocrine, the thyroid dysfunction, hypophystitis, type 1 diabetes. But for today's program, we will be focusing on colitis, hepatitis, pneumonitis, thyroid dysfunction, hypophystitis, and type 1 diabetes. So diarrhea, colitis, it's important that we do rule out other potential etiologies. Of course, the most common infection and what we commonly see is C. diff, but we want to do rule out other potential infectious processes as well. And, you know, we should really, if a patient is an immune checkpoint inhibitor, really consider the patient is potentially having an immune mediated colitis, and really get our other services involved with having GI involved to help us potentially have a colonoscopy, to have a better evaluation and further investigate. And as we see here on the right with the depictions of a colonoscopy, we see that starting with the bottom, we see a mild inflammation. This patient has a colitis with patchy erythema, aphtha, edema, and some normal mucosa. And then this moderate colitis we see here with the second set of pictures with most severe inflammation. You see the diffuse patchy erythema, some superficial ulcers, and then the very top one, you see the more severe inflammation with the large, deep ulcerated mucosa. So again, really involving your other specialty services to help manage these patients when they do get this colitis is helpful to also just diagnose them. And of course, having a low threshold to start patients on corticosteroids, we would start them at 1 to 2 milligrams per kilo per day or its equivalent, and really just having a low threshold to really starting them because of the potential for bowel perforation. And budesonide, you know, there was a randomized double-blinded placebo-controlled trial enrolling about 150 patients, and seeing what their benefit was with budesonide, and they really saw that there was no additional benefit. And this is what the ipilimumab, and there was no additional benefit with these patients, and having the budesonide given prophylactically or preventing any greater than grade 2 or greater diarrhea, colitis. So there really wasn't any additional benefit. If the patients don't respond or slow to improve, respond to the corticosteroids or the steroid refractory, considering additional immunosuppression with an anti-TNF, and that would be infliximab, and it's dosed at 5 milligrams per kilo every 2 weeks. And usually patients respond with a few doses, approximately 1, maybe up to 3, but they usually do respond pretty well. Hepatitis. Hepatitis, most patients are typically asymptomatic. This is something we typically capture, you know, when patients come in and we follow them with labs and we see them in their chemistries or the liver function tests. And so it's important to know something that we do monitor these patients closely with their labs. And we see an elevation in their AST and their ALT, typically happens approximately 6 to 14 weeks after they start treatment. And if a patient does have a grade 1, of course, we do want to monitor these patients closely to ensure that they're not having a greater toxicity. If a patient does have a grade 2, we want to continue to monitor these patients closely and initiate corticosteroids at 0.5 milligrams per kilo per day. At a grade 3, we want to increase the corticosteroids to 1 to 2 milligrams per kilo per day. We are withholding the immune checkpoint inhibitor. And of course, we will be monitoring them more closely with the liver function test at 1 to 2 days, because we want to ensure that they're having the appropriate treatment response and going in the right direction direction, having their LFTs starting to decline. If a patient has a grade 4, absolutely we'll be discontinuing the immune checkpoint inhibitor, continuing with the corticosteroids at 1 to 2 milligrams per kilo per day, and of course following these patients closely, monitoring their liver function tests every 1 to 2 days, ensuring that they're having the appropriate treatment response. And of course, we do want to be thorough with our patients and rule out other potential etiologies and rule out doing an autoimmune hepatitis panel, do iron studies, and of course a viral hepatitis panel, and also consider disease progression, ensure that this is not somehow a process from disease progression. And we want to ensure that once a patient recovers to a grade 1 or less, that we do taper them over 4 to 6 weeks. And this is going to be so critical that we do this slow taper. If we do taper them too quickly, then they can rebound. So this is so important that we do this slowly. And if a patient does not improve or recur during their taper, you can consider administering azathioprine or mycophenolate. And infliximab is not something that should be considered for this particular IRAE because of the hepatotoxicity. Pneumonitis. Pneumonitis is something that we do see, and it can be sometimes challenging to distinguish if a patient specifically has, underlying lung disease or lung metastases. So it's important, again, establishing the baseline and seeing how patients differentiate from their baseline. So if you have a worsening of a persistent dry cough, or maybe they didn't have one and now they are having one, worsening dyspnea on exertion, that we do rule out other potential etiologies like disease progression, infection, a PE, and of course imaging these patients. And here we see on the right the images of the potential radiographics types of pneumonitis that we can see. So we can see the cryptogenic organizing pneumonia-like, we can see ground-glass opacifications, interstitial-like type, hypersensitivity type, and pneumonitis not otherwise specified. So there's different types of pneumonitis that we can see, and we do rely to our radiologists to provide us with those reports to when we do get the imaging for our patients. Management, how do we manage our patients? We do want to start them on corticosteroids based on the grade, but if a patient has a low grade, we can monitor them and see how they do. And again, grading is critical so that we just determine where they're at and if we want to monitor or initiate corticosteroids. And we may need to add additional immunosuppression if patient is not having the appropriate response. Another thing that is really critical is that we really look at the patient holistically and really discern their symptoms of pneumonitis from other potential etiologies. And we really have to think about our patients. Our patients don't just have a malignancy and don't just have symptoms from their immune checkpoint inhibitor. They do have other underlying medical conditions, comorbidities, and it's important that we really do the multidisciplinary approach to our patient once they do present with symptoms and rule out other potential etiologies, because they can have other underlying comorbidities that can really truly have the patient present with symptoms of pneumonitis that really will mimic pneumonitis, but not be pneumonitis. Patients can have, previous radiation, autoimmune features, history of chronic infiltrates, asbestos exposures, comorbid lung conditions such as history of COPD, evidence of obstruction, a baseline O2 stats, patients, depending on the agent that has been chosen with their cancer-related features, their NGS profile, their cardiorespiratory status, if they have life-hearted failure, pulmonary hypertension. So these are all things that we really have to look at and really evaluate and ensure that there's not other conditions going on with the patient, other comorbidities that can potentially be contributing to the symptoms that can truly mimic pneumonitis and not be pneumonitis. So really involving a multidisciplinary approach to our patient and rule out other potential etiologies. Thyroid dysfunction. So thyroid dysfunction is something that we can see. We could either see hyperthyroidism or hypothyroidism, or we may initially see hyperthyroidism followed by hypothyroidism. So hyperthyroidism, you get this leaky thyroid. Patients can be symptomatic with the tachycardia, the weight loss, and of course we can do some symptomatic management with the beta blocker if they have the tachycardia. Of course, get endocrinology involved to really help us manage these patients further. And the duration is typically 2 to 6 weeks. Once patients become hypothyroid, they're recovering in the depleted phase, and then they have the opposite effects. They have fatigue, they have constipation, the hair and skin changes. And so then again, involving endocrinology to help supplement these patients. And the hypothyroidism can be permanent or it can be transient. And so, and for this particular IRAE, we don't need to hold the immune checkpoint inhibitor, just manage the patients as clinically indicated. And as we see here on the right on the graph, we see a patient with subacute, we see subacute thyroiditis, and we see what happens with the T4, the TSH, and the radioactive iodine uptake. And basically when there's the thyrotoxic, everything really just essentially drops. When there's the hypothyroid, we see that the TSH increases, and when now that there's a euthyroid, we see that radioactive iodine uptake increases, and the TSH and T4 sort of levels off at a more appropriate level. Hypophystitis. Hypophystitis is more typically seen with the CTLA-4 inhibitors. It is such a unique toxicity that it's once you see it when patients have, as a result of the increased cranial pressure, it is so unique. Patients will present with severe headache, pressure behind the eyes that really is truly not alleviated with any over-the-counter medications or even opioids. So it's really such a unique, these patients will be coming to see you because of their unique symptoms, and they can have blurred vision, or they can present with these hormone deficits that they present again with this profound fatigue, hypotension, weakness. And so it's really important that we do evaluate these patients, do a pan-hypopituitary, a panel with the ACTH, TSH, FSH, LH, GH, and prolactin. And it's important that if we are going to initiate corticosteroids, that we do draw the labs first prior to initiating the corticosteroids. And of course, you want to differentiate from primary adrenal insufficiency or hypothyroidism. And so if we do have any suspicion, we could always do an MRI with pituitary cuts to further evaluate. And here we see a patient on the right, on the top with image A, that this particular patient at baseline, we see that the pituitary is normal. We could see here, oops. And at image B, now here the patient presented symptomatically. Now we see that the pituitary is enlarged, and now we understand why patient is clinically symptomatic, and really the corticosteroids will help reduce the size of the pituitary, and patient will have relief of symptoms. The pre-treatment screening recommended by SITC. So really establishing the patient's baseline, this is going to be so critical because we really want to know how patient differentiates from the baseline, how they, and so that we can know how to intervene. So really establishing their history, do they have any underlying autoimmune conditions, infections, any endocrine history, any organ-specific diseases, what's their bowel habits. The reality is some patients have one bowel movement every 4 days with multiple laxative, where one patient may have 3 bowel movements a day, and really establishing that baseline, because then when we grade them, that really will impact how we grade. Derm, you want to do a full head to toe, including a mucosal exam. Pulmonary O2 sats at baseline, I think we all have those at baseline. Cardiovascular, having an ECG at baseline, and I think we almost all of us have those on our patients, but troponins we may not, so something to all consider having at baseline. Blood tests, having the basics, CBC with diff, CMP, the TSH, T4, hemoglobin A1C, total CK, fasting lipid profile, and the infectious. with the hepatology, the hepatitis, the CMV, the HIV, and TB. So one thing to consider is that our patients may come from an emergency department because they were symptomatic and then they were diagnosed with disease, and that's how they came to us. But our patients may have not had any primary care. So these basic primary care labs, they may not have a baseline. So it's important that we always do consider getting these. And if they do have them, we may not necessarily have access to them. For patients who are at high risk, getting the endocrine tests, an AM, cortisol, and ACTH, cardiac tests with the BNP or NT-proBNP, pulmonary function test, and the 6-MWT. The approach to treatment, really the grading is going to be so critical, really how a patient differentiates from the baseline, how they're deviating from the baseline, and then grading. Grading is really the CTCAE, how we're going to intervene, what our intervention is going to be. So that's really going to be key. The resources, we have the CITSI Toxicity Management Working Group, the CTCAE, and the NCCN. These are all great resources that are very organized, that can really go based on each individual IRAE for the CITSI and the NCCN, and really just follows it in a very organized manner based on each grade on how to manage each individual IRAE. So I highly recommend you to look at those. But what's ultimately our first line of treatment? It is high dose corticosteroids. That's what we do. But with, of course, any endocrine IRAE that we have, we would receive patients as per institutional guidelines as clinically indicated. For patients who have a dermatologic or ophthalmologic IRAE, for any low grade, grade 1, grade 2, we would just do topical corticosteroids. Over-the-counter drugs, especially for patients who are having a questionable immune-mediated colitis, giving them an antidiarrheal. I mean, that's probably not such a great idea because it can potentially mask a higher grade colitis. And so then we really are not potentially intervening as we should, or perhaps we think that patient is not having an IRE because the diarrhea is controlled, and really putting the patient at risk for a bowel perforation. So really not something that is recommended for the antidiarrheals. The general corticosteroid management, for a grade 1, we really don't do anything. For a grade 2, you can start prednisone at 0.5 to 1 milligram per kilo per day, or its equivalent of IV methylprednisolone. If patient does not improve in 2 to 3 days, you can increase it to 2 milligrams per kilo per day. And once it improves to a grade 1 or less, you can taper them slowly over 4 to 6 weeks. And of course, once you initiate the corticosteroids, you do want to hold the immune checkpoint inhibitor. And if the patient recovers to a grade 1 or less, then you can resume the immune checkpoint inhibitor. And then we do want to cover these patients prophylactically for GI with the PPI. For a patient who has a grade 3, grade 4 IRAE, we want to start them on prednisone for 1 to 2 milligrams per kilo per day of IV methylprednisolone or its equivalent. And if it does not improve in 2 to 3 days, we do want to add additional immunosuppressants, of which we'll get into in just a sec. Once it recovers to a grade 1 or less, we can taper these patients over 4 to 6 weeks, again, a slow taper. For the grade 3s, we want to hold, and if we're not able to taper them in 4 to 6 weeks, we want to discontinue the immune checkpoint inhibitors. We do want to give patients GI prophylaxis, a PPI, and if patients are going to be on 30 milligrams of prednisone or greater for greater than 3 weeks, we do want to cover them for PJP prophylaxis. For grade 4, we want to discontinue the for the immune checkpoint inhibitor, and of course, and continue the PPI GI prophylaxis and the PJP prophylaxis if they're going to be on 30 milligrams of prednisone or greater for greater than 3 weeks. The additional immunosuppressives that are available to treat these IRAEs, for colitis, it would be infliximab, the anti-TNF alpha antibody dosed at 5 milligrams per kilo. And it's given every 2 weeks, and typically patients just need a couple of doses. For those patients that perhaps maybe have latent TB, cannot have infliximab, the Vitilizumab is another alternative, the alpha-4 beta-7 inhibition. It's gut selective, and this is something that can be more given with the CTLA-4-induced colitis, and it's dosed at 300 milligrams, and it can be repeated at week 2 and 6. For pneumonitis, there's a mycophenolate. It inhibits the T and B cell proliferation, dosed at 1 gram twice per day. And there's also the high-dose IVIG. For cutaneous, there's the typical tacrolimus, a calcium inhibitor. And then there's for bullous pemphigoid, there's rituximab. For eczema, there's dupilumab. For Lynch node rash, there's infliximab. And for urticaria, there's omalizumab. Now going on to rare but serious adverse events. So these are really uncommon IRAEs that we see really seldomly. For today's program, we're just going to focus on myocarditis and type 1 diabetes mellitus. So in looking retrospectively at immune checkpoint inhibitors and the IRAEs and looking at the cases of fatality rates, we see that myocarditis was the greatest fatal IRAE. And when looking at the median time to onset of the fatal IRAE, we see that myocarditis, when given in combination with IOIO, occurred much sooner at 14.5 days versus 40 days when given alone with ipilimumab or the anti-PD-1. So it's more commonly seen with this myocarditis, more commonly seen with the anti-CTLA4, but highest and seen in combination. And so it's, of course, with the myocarditis, you'll have the typical cardiac symptoms with the dyspnea, the chest pain, fatigue, dizziness, syncope, palpitations. And so if patients are imaged, really, there's really nothing that really is significant that's seen on the imaging. But if there's any suspicion for myocarditis, drawing troponins, and if they're elevated, then there's a high suspicion that you should really consider the patient is having an immune-mediated myocarditis. And the management, we told the immune checkpoint inhibitor, initiate cortical steroids based on the grade, and of course any heart failure support. And do remember that the myocarditis can overlap with other RAEs like the myasthenia gravis and myositis. Type 1 diabetes, this is something that we see more commonly with the PDL1 pathways. And so this is something that, again, going back to monitoring patients' labs closely, because this is something that can be quick, that we can see quickly come on fast, and really monitoring those labs is going to be critical so that if we see a sudden onset of hyperglycemia, that we can start acting appropriately, and patients tend to more easily have the diabetic ketoacidosis, and really important again to monitor patients prior to each treatment. We don't give any immunosuppressants for these patients. The pancreatic beta cells degrade pretty quickly, and really we just manage these patients as medically appropriate with insulin. And of course, refer these patients to our specialty services with endocrinology to help us further manage these patients. The impact of IRAEs on cancer outcomes. So here we see the effect, the survival with patients, the melanoma patients who were treated with ipilimumab and nivolumab, and who had IRAEs in their induction phase and discontinued in the induction phase. So they didn't continue, they didn't complete their induction phase, versus those patients who continued on with their treatment. And we see that the overall survival was equally, there was no differences for those patients who discontinued versus those who continued. The overall was survival was equally the same. So autoimmunity as a prognostic marker, we've heard this before. It's always been a question that's been posed. If a patient has an RAE, does this mean that they're going to be to have a better response? And as we see here on this retrospective data, we see that patients on the left who had an IRAE and those patients who did not have an IRAE on the red, we see that those patients on the blue who did have an IRAE, that they'd had a better survival. When we look here on the right, those patients on the blue who had an IRAE that did require immunosuppressives versus those on the red who did not have an IRAE, regardless of patients needing immunosuppressives with the blue, they did have a better survival. So really, having an IRAE, this does support that patients do overall do better and have a better, this showed that they had a better survival. The impact of steroid management on patient outcomes, of course, once we start patients on corticosteroids to manage the Irees, our patients do get a little fearful that we're going to dampen their immune response. And so here we see that this is data that was presented at ESMO, that on the left, we see that the purple line patients with no steroids, the green with the baseline steroids, and the red with the early steroids. And when we go on the right, we see here that the green were the patients that were treated with steroids, but it was non-cancer related. So perhaps patients were treated for like RAE management. And then we look at the red for patients who were treated for cancer-related symptoms. And we see that the patients who were treated with corticosteroids for cancer symptoms, they did, their overall survival was affected at 1.9 months versus those who had non-cancer related corticosteroids baseline at 13.4 months. So really just speaks volumes that if patients need to have IRAE management with corticosteroids, that it should be done, that really the patients who did poor were those who had to have the corticosteroids as a result of their cancer symptom management. Rechallenging with immune checkpoint inhibitors after IRAEs. So here we had patients who had immune checkpoint inhibitor induced IRAEs, and they resolved to a grade 1 or less, and then they were rechallenged and they were treated with either PD-L1, PD-1, or anti-CTLA-4. And so here we see that 48% of these patients who were retreated had no subsequent IRAEs. 26 had a new recurrent IRAE, and 26 had a new IRAE. When we look based on the grade, those who had a grade 1, grade 2, and were rechallenged, 13% of them had no subsequent IRAEs, and 12 had new or recurrent IRAEs. Those who had the higher grade, the grade 3, grade 4s, 5 had no subsequent IRAEs, and 8 had new or recurrent IRAEs. So really, when we're challenging patients with the higher grades, it's really important to be cautious and really monitor these patients closely because of potential IRAEs. Cellular therapies and adverse events and management. The CAR T-cell related toxicities, the more commonly seen, as Dr. Young mentioned earlier, the cytokine release syndrome, the immune cell associated neurotoxicity, the hemophagocytic lymphohistiocytosis, macrophage activation syndrome, Hla Mass. This is less common, the anaphylaxis, the B-cell aplasia, and the hypogammaglobulinemia. But for today's program, we're just going to focus on the first 3. CRS and neurotoxicity, usually they're overlapping. You see the CRS happen first and then followed by the neurotoxicity. They can happen independently of each other. And the CRS typically happens at day 2, day 3, and the neurotoxicity usually happens at day 4, day 5. And the CRS can typically be managed symptomatically, and we'll go into detail with regards to all that in the next couple of slides. But the risk factor is the high disease burden, and should potentially just given a treatment to decrease the disease burden for patients because of this risk factor. The high infused CAR T-cell dose, perhaps new CAR T-cell therapies that are coming out, giving them a dose escalation, the high intensity lymphodepletion regimen, pre-existing endothelial activation, and severe thrombocytopenia. The cytokine release syndrome, as you previously saw the slide earlier, it's a multi-organ system that are affected, with the constitutional symptoms, with the fevers, the rigors, the GI, the nausea, vomiting, the respiratory, the tachypnea, hypoxia, the coagulopathy, the hyperbilirubinemia, transaminitis, the tachycardia, hypotension. So really affects multiple organ systems, and really the need to involve the multiple specialties to really help manage these patients. The cytokine release syndrome occurs in approximately 70% of patients, but those with severe grade is approximately 12 to 47%. The median onset, as I previously mentioned, was 2 to 3 days, and the duration is about 7 to 8 days. And there's different grading system. It's the MSKCC, the CAR-TOX, and the STCT. But what really drives the CRS toxicity is the hypoxia and the hypotension. So now going on to the grading, if a patient has a grade 1, a fever greater than 38 degrees Celsius and CRS that's greater than 3 days, we really do nothing but support the patient with antibiotics, G-CSF if they're neutropenic, a grade 2, fever and hypotension, adding the tocilizumab at 8 milligrams per kilo and 4 doses max. And if patient is refractory with hypotension, then the DAX at 10 milligram every 6 hours, and then continuing the supportive care with IV fluids, pressors, and manage as a grade 3 if there's no improvement in 24 hours. Once a patient is a grade 3, of course, the patient is in the ICU, they're continuing with the pressors, the IV fluids, having an echocardiogram, continuing with the DEX every 6 hours, the tocilizumab at 8 milligrams per kilo. And if a patient is at a grade 4, they're in the ICU, they're on mechanical ventilation, multi-organ toxicity management, they're continuing with the DEX and the tocilizumab. Here we see on the bottom of the right, a writing sample. We see that a patient had a mini mental exam and there really wasn't much change in their score. But at day 4, we see the writing sample. At day 5, we see a great decrease in the penmanship. We see this great change. And then day 6, we see back to normal. The neurotoxicity. The neurotoxicity it is also called the CAR-T related encephalopathy syndrome, the CREST, or the immune effector cell-associated neurologic syndrome, ICANS. And again, similar to the SRS, it occurs about 20 to 64% of patients greater than grade 3. It occurs in 11 to 42%. The onset is later. It happens after the CRS. It follows at 4 to 5 days, and the duration is about 5 to 12. So the I-score, the higher the I-score, the better. So if a patient has a grade 1, their I-score is 7 to 9, and then they awaken spontaneously. We really do nothing. At a grade 2, their I-score drops to grade 2 or 3 is 6, and they awaken to voice, and we do nothing. At a grade 3, their I-score drops significantly. It's 0 to 2. They only awaken to tactile stimulation. They may be having seizures on EEG or clinical seizures and some focal edema noted on imaging. At a grade 4, patient's I-score is 0, unarousable, life-threatening seizures, hemiparaparesis, deep focal motor weakness, severe diffuse cerebral edema, the cortical posture. So this is for the CREST. Now going on to Hla Mass. So Hla Mass is something that is really seldomly seen at approximately 1%, and it's really as a result of hyperactivation of the macrophages and the lymphocytes. And really the way it's managed is with an anti-IL-6 and corticosteroid therapy. If a patient has no improvement in about 48 hours, considering adding further immunosuppression with etoposide, a dose at 75 to 100 milligrams per meter square, and can be repeated every 4 to 7 days. But there's a very specific criteria that needs to be met for a patient to be diagnosed with Hla Mass. So typically after 5 days after the CAR-T infusion, patient will have an increase in their ferritin of greater than 10,000. And then they have to meet 2 of the following criteria. They have to have at least a grade 3 or greater of increased serum billy or AST or ALT, or a grade 3 greater oliguria or increased serum creatinine levels, or grade 3 greater pulmonary oedema, or presence of the hematophagocytosis in bone marrow or organs based on the histopathologic assessment of the cell morphology and or the CD68 and the immunohistochemistry. So immunotherapy in special populations, patients with autoimmune disorders, evaluating patients who were treated with ipilimumab, and in melanoma patients specifically who had underlying autoimmune conditions, and they saw that those patients, 29% of them, had a flare of the pre-existing underlying autoimmune condition, and 29% experienced new IRAEs, but 56% had no flare or IRAEs. Melanoma patients treated with PD-L1 inhibitors, 38% experienced a flare of the underlying autoimmune condition, 29% experienced new IRAEs, but those patients that remain on their on immunosuppressives had a lower response rate for 15% versus 44. But overall, there really was, they had the same response with patients who had underlying autoimmune conditions versus those who did not. The immune checkpoint inhibitors and with patients with solid organ transplant or stem cell transplant. So patients who relapse after an allogeneic stem cell transplant who were treated, there was a study, they were evaluating patients treated at 3 milligrams per kilo with ipilimumab or 10 milligrams per kilo. And at the 3 milligram per kilo, there really was no response, but at the 10 milligram per kilo, 32% had a response, 14% had GVHD, and 21% had IRAEs. When treated with the anti-PD-L1, 77 had a response, and 26% died due to new onset GVHD. The solid organ data is really limited. Most of it is really with a renal solid organ transplant. There is some data with other solid organ transplant, but it's mainly renal. And in a retrospective study, they did see that 81% of patients did have loss of the graft, and there was 46% deaths. And the loss of the graft does happen pretty on the rejection happens on pretty early on, at approximately the median onset is 21 days. So the PD-L1 pathway, it seems to be the more critical in allograft immune tolerance compared to the CTLA-4. The importance of patient education, this is so critical. It's really critical that patients understand that, that they can potentially have these immune-mediated adverse events that can really mimic a worsening of their underlying comorbid conditions or just any underlying, other underlying health problems, so that they can just, all they really need to know is that they need to communicate with us how they differentiate from the baseline, and that we'll tease out whether it's related to their underlying disease or whether it's related to the immune checkpoint inhibitor, but that prompt communication and intervention is essential. And that really, oftentimes we see patients in the infusion center and they're getting something in the arm and they always say, I'm getting my chemo. It's really important that they have a basic concept of what they're getting. They're getting an immunotherapy and not a chemotherapy. That is such a critical piece, that they have a basic understanding of the mechanism of action of what they're doing. It doesn't have to be very critical, very in-depth, but something basic, so that when they get seen with another provider, emergency department, that they can verbalize what the appropriate treatment is that they're getting. And also that we set realistic expectations for our patients, that they understand that these IRAEs isn't going to happen to everyone, that if they do happen, that they're very, they're likely to resolve over time. However, if they do have endocrinopathies, those may potentially be permanent, but that we do have the ability to manage them and resolve them with time. But it's not going to happen to everyone. If they think that they're going to be sick or have these immune mediated reactions and be even sicker, they're not going to be likely to want to start these treatments. But again, expectations is important. Educating the healthcare continuum. This is important because the likelihood is that our patients may not necessarily come to us for their management of their IRAE. If a patient travels to us for the treatment, but perhaps are managed locally, maybe they're managed locally by a local oncologist, or maybe it may not even be a local oncologist, it may just be a local primary care doctor. Depending on some community practices, their local doctor may just be a community doctor. So it's important that the community provider be aware of these new novel agents, and I understand that could be quite challenging for them to keep up with all these new novel agents that are coming out, but at least keeping the lines of communication with the treating provider, the treating oncologist, so that we can help manage these IRAEs. The emergency departments, that's the first line of defense for our patients when they do experience any IRAEs. And so for them to really understand that when they see an oncology patient, that they don't automatically think chemotherapy and treat a diarrhea with IV fluids, antidiarrheals, and send them on their way, because that's not going to be the appropriate management, that they do understand that there is these new novel agents that really need to be treated and worked up quite differently. And again, this is again the importance of patients having some basic understanding of what they're receiving so they can verbalize it to the emergency department providers. The additional resources, and I do have a case study. Do we have time for the case study?
We do, yeah.
Okay, awesome. So here we have an 82-year-old non-smoking male with metastatic adenocarcinoma. NGS was done with no actionable mutations, was treated with first line with the Keynote 189 regimen. At maintenance 5 with the pembrolizumab, pemetrexed, presence of profound fatigue, decreased appetite, dyspnea with mild exertion, and cough. How do you manage based on symptoms? You treat and obtain a chest x-ray, treat and give antibiotics, hold treatment, draw labs, include a CBC, CP, TSH, cortisol, CT of the chest, delay treatment and start corticosteroids, and reevaluate symptoms in a week. Oh, fantastic. That's great. So that's exactly what we did. We were thorough. We wanted to make sure there was no endocrinopathies that was ongoing, contributing to patients' fatigue. We did do a CT of the chest, and here are the labs. The labs were essentially unremarkable. The CT of the chest demonstrated new patchy ground glass attenuation in the right lower lobe, suggesting pneumonitis. We treated this patient with corticosteroids. Patient clinically improved. We did cover the patient for PPI, GI prophylaxis, and of course with PJP prophylaxis. And once patient recovered to a grade 1, then we tapered him over 6 weeks, and he's done actually pretty well and recovered beautifully from his pneumonitis. Now moving on to the next case study, we have a 59-year-old male, previous smoker with a past medical history of COPD, CKD, CHF, cardiac disease, insulin-dependent diabetes mellitus, psoriasis, and has unresectable stage 3 squamous non-small cell lung cancer, completed chemo-RT, and he is followed now to be treated with durvalumab for a scheduled 26 cycles. But he presented after cycle 16 of durvalumab at an outside hospital with symptoms of increased dyspnea, mild exertion, hypoxia that required O2. He had a CT of the chest at the outside hospital that demonstrated diffuse mild interstitial infiltrates throughout both lungs. How do you manage based on those results? Start corticosteroids for possible pneumonitis, start empiric antibiotics for possible pneumonia, evaluate underlying comorbidities for possible contribution of causative symptoms, start empiric steroids, antibiotics, and discharge with supplemental oxygen. Okay, great. I do like to see the different responses here. So I'll tell you what happened to this particular patient. So this particular patient at the outside hospital, because he was on immune checkpoint inhibitor, and he had these infiltrates on his CT of the chest, they automatically attributed the infiltrates to the immune checkpoint inhibitor, and they treated him with high-dose corticosteroids, and patient continued to be symptomatic and really was not improving. Patient eventually made it to us. We did evaluate him, had a CT of the chest. It did not show any immune-mediated pneumonitis. In fact, it showed that the patient had was in cardiac failure, needed to have dialysis, had pulmonary edema, was fluid overloaded, and really his symptoms were all related to his underlying comorbidities. And really emphasizing the point that it's so important to really evaluate the patient as a whole, look at their underlying comorbidities, and see, and not always attribute the symptoms to the immune checkpoint inhibitor. And once the underlying cardiac disease and patient was dialyzed, that he actually symptomatically improved, and again, not related to the immune checkpoint inhibitor. And that's it. Thank you so much. Any questions?
Thank you, Blanca. There are, here, let me stop this so you can see it. There are 2 questions in the Q&A button. If you see that at the bottom of your Zoom, if you wouldn't mind answering those in text so we can keep moving along, if that's okay.
Absolutely.
Thank you.
Thank you very much for that excellent talk. I think it's it's really obviously an incredibly important topic, and one that sort of goes throughout practitioners, who take part in the care of patients.